Good day, students. Dr. Raskob here. I'm pleased to be back with you to talk about health reform in the United States. And this is the material covered in Chapter 10 of your textbook. And this session we are doing together now really is what was to be covered in person together with you on April the 1st. We will go through briefly the history of health reform in the United States. We'll talk about some of the challenges to achieving health reform. We will discuss the key provisions of the Patient Protection and Affordable Care Act of 2010, which is usually called either the Affordable Care Act or the ACA. And this is a landmark legislation, the most significant piece of health policy making in the United States in the last 50 years. And its implementation continues. There are ongoing state and federal court cases related to legal challenges to the law, and there is a significant interplay of both legal and political influences with regard to this legislation. So that's what we'll cover in this chapter. And then in a future discussion with you, we will talk a little bit about health reform in the context of the 2020 election. Now, while there is general agreement amongst experts and often even among policymakers about what the problem is with regard to U.S. healthcare or the multiple problems, there is certainly no general agreement regarding the solutions. But in general, most policymakers believe that the problems are clearly the high cost of healthcare and the lack of affordable healthcare for many, the high rates of uninsured, the health disparities that persist in our population, and there are concerns about the quality of care and how do we provide a consistent quality of care to our citizens. Now, there have been numerous health reform attempts in the United States, and the next slide or so will summarize some of those. But the major point is that all prior attempts to the Affordable Care Act at the national level regarding health reform, in which the goal was to create universal or near universal coverage, had failed. Now, there had been some success prior to the Affordable Care Act at the state level. Massachusetts, for example, under the direction of Republican Governor Mitt Romney, and with a 85% opposition party Democratic legislature, they were able to work together and pass meaningful health reform in that state, which brought the uninsured rate down from approximately 15% to about 2% about 5 years after the legislation, and documented a absolute reduction in age-adjusted mortality in the state of about 3%. So it can be done when the parties work together, but this has been very challenging. And as you know, the Affordable Care Act passed now just 10 years ago this March in 2010, was one of the most partisan pieces of legislation passed in our recent times. So there are numerous tensions in achieving health reform. They're listed in this slide. Critical ones are state flexibility versus achieving some sort of national uniform approach to healthcare. And this is grounded, of course, in many other issues that we have relating to state rights versus federal rights. There is certainly a disagreement about what the role of government should be with regard to healthcare, and role of the private sector similarly is not agreed upon to any degree for sure, and you see that even with some of the current candidates for the Democratic nomination. Another tension has been defining actually what the primary objective is first, and then what are trade-offs with other aspects of health policy. So, for example, is our primary purpose to achieve health equity, universal access to health care under a social justice paradigm, or is it to improve health outcomes, Is it to control or reduce the cost of healthcare for the many people who have insurance already? Is it primarily to constrain fiscal constraint of the federal government related to government spending on the entitlements, for example, of Medicare and Medicaid? And what is the scope of coverage that should be provided for individuals who are covered? What is typically included in health reform may be efforts to reduce the number of insured, efforts to contain costs, efforts to reduce medical errors and thereby improve the quality of care. Remember that the Institute of Medicine, now called the National Academy of Medicine, estimated that up to 100,000 patients die each year in the United States due to medical errors. Is the purpose, do we want to strengthen patient rights? Do we want to build and strengthen the public health infrastructure? And do we want to reduce the cost of medical malpractice? All of these are legitimate goals and may be included in one form of health reform or another, or may have a greater or lesser emphasis when we say health reform to different individuals. Now, there are barriers or difficulties to achieving health reform in the United States. Our culture certainly is a starting point that makes it challenging because we have a individualistic libertarian nature. This is greater in some states than in others, and certainly in Oklahoma this is a strong view, individual rights, and the tension between a social justice viewpoint or a market justice viewpoint and an emphasis on personal responsibility rather than a collective engagement of society and government to help. There's certainly a lack of agreement as to whether healthcare should be a right in the United States. There are very partisan views on the role of government. There is some who want to shrink government, not have big government, decrease the role of government in our lives, and that certainly is a discussion when it comes to healthcare. In general, the states have been the place where social welfare issues such as this are addressed. The federal legislative rules, for example, how the Senate operates, the filibuster versus reconciliation type of legislation, as to whether a two-thirds majority or just a simple majority is required for passage. These actions and these rules have been problematic and have been used by the parties against one another, each other in political areas. Now, there are powerful interest groups at the national level, particularly, who are either for or against health reform. For example, the American Association for Retired Persons, or AARP, carries enormous sway and weight with Congress with regard to any type of health reform. And similarly, Pharmaceutical Manufacturers Association and the Association of Health Insurance Plans are also large organizations that spend a lot of money on lobbying and have extensive lobbying efforts with regard to any legislation that will influence health care. And finally, a cultural thing also, I think, has been the interests of the insured. So at the time of the Affordable Care Act being written in 2010, interests of the 85% of the population who are insured crowd out or displace the interest of the uninsured. The uninsured, of course, have a primary interest in getting access and getting covered access to healthcare, whereas the insured, the people who are insured already, which is by far the largest group of constituents, the 85% of people who have some form of health insurance, their primary concern has been to reduce the cost of their healthcare and their insurance. And these two different interests are in tension sometimes, but the larger group, the insured population, the people with higher incomes and access to making their voices heard with their congressional representatives, have crowded out often the others, the lower income, lower socioeconomic status, whose focus, of course, first and foremost, is to actually gain access. Now, this slide lists key attempts at national health reform that failed in the past. And the most recent, of course, before the Affordable Care Act was the Health Security Act of the Clinton administration in 1993. But the important point from the slide is not the specific details of each attempt, and that's not the core message here. The message here is that America has been trying to achieve some key health reform, health insurance and health reform since more than 100 years ago, back to 1912 and 1915. So you can see that this has been a long-standing topic in our society, one that has been a difficult one to bring consensus and resolution to. Now, in 2009, immediately after his election, President Barack Obama articulated guiding principles for health reform. He decided that for the Affordable Care Act, he wasn't going to get down in the weeds and be all involved in the details. He would leave that to Congress. The Democrats at that time had majorities in both the House and Senate. And he said, I'll leave to Congress and the appropriate committees there the sorting out of the specific policy details. But whatever policy you come up with, we want you to be sure that you are in line with these guiding principles, that you will protect families' financial health. That means that out-of-pocket expenses for healthcare will be reduced and bankruptcies will be avoided, and we'll say more about that later. We want to make health insurance more affordable to the average American. We want to aim to achieve universal coverage of health insurance for all Americans. We want to provide portability of insurance coverage, meaning that no American should be afraid to have to change their job or want to change their job or start out on their own as an entrepreneur and start a new business for fear of losing their health insurance. We wanted to solve that problem. He wanted to be in line with really what the American people said in many, many polls, that they want choice. Choice is very important. Choice of both coverage and choice of providers, choice of doctors, choice of hospitals, choice of providers is very, very important from many, many polls of the American people. The President Obama really understood the importance of investing in disease prevention and wellness efforts, and he so made that a key principle also of his list here in terms of what health reform should achieve, that he wanted to improve patient safety, address that issue of medical errors, and to improve the quality of care for all Americans, and that whatever plan and policy was developed to do this and to achieve all of these guiding principles, it should be fiscally sustainable over the long term. It should reduce costs. The healthcare industry should be incentivized to improve productivity and revenue. And so these were his core guiding principles, and he then said to Congress, you now do the work, make the sausage, so to speak, and come back with a plan that we will pass to improve health and healthcare in the United States. Well, the end result of all that is the Affordable Care Act. There continues to be significant debate about the success of this legislation, but there's no question, as I mentioned earlier, it is the most profound sweeping piece of health policy in this country in the last 50 years, really since the introduction of Medicare. Now, the Affordable Care Act wanted to address, as President Obama had articulated, access to care, the quality of care, and the cost of care. And this has become to be known as the so-called triple aim that we want to achieve. And past attempts have always ran into difficulty in the tensions between achieving one or more of these goals of the triple aim. And generally it come to the conclusion that it was pretty easy to achieve two of the three, but not all three at the same time. If you improve access and you improve quality, you're going to increase cost. That was a general thought of the time, that it was very difficult to achieve all three at the same time. If you want to really focus on reducing cost, you may end up with lower quality and or lower access. Now, the Affordable Care absolutely did eliminate denial of coverage due to pre-existing conditions, a major step forward. It insisted on using community rating rather than medical underwriting, as we've talked about earlier in this course, for setting the premiums of health insurance policies. It instituted an individual mandate that all individuals must buy insurance or pay a fine. Excuse me. And it implemented an employer mandate to provide insurance or pay a fine. So these were four crucial anchors to the policy. No more denial of coverage due to pre-existing conditions, setting the premium based on the pool of participants and not on an individual's health situation or their use of health care historically, and mandates for the individual and the employer. It also brought in the very popular element that young people can stay on their parents' plan up until age 26, that the states should expand Medicaid eligibility in order to broaden access and achieve that near universal access, and Medicaid expansion being the primary mechanism by which very low income individuals would be brought into the fold and given access. It established insurance exchanges for self-employed people or small business, small company employees where their company did not offer health insurance and where they could go to online marketplaces to shop for an appropriate plan. And if you were in a particular low or moderate income status, there were government subsidies to help you pay for this plan. This has been one of the problems in the past, is that these individuals really were in a bind in getting health insurance. Often they would be denied due to medical underwriting, or they would be charged such an exorbitant fee that it wasn't worth it for them to get the health insurance. And it was really felt that by providing these exchanges where many people could pool together to buy policies and that are put there by insurance companies in competition, that this would be a good mechanism to ensure the individual or the person who works for a small business that doesn't offer health insurance. We previously talked about the medical loss ratio. Medical loss ratio is the proportion of the monthly premium that must go to the provision of services to the beneficiary. So it can't be used for marketing or administration or research or advertising. And so the medical loss ratio was defined to be 80% or greater as a requirement, so that the vast majority of an individual's premium would actually be going to a benefit that they would receive. And finally, the Affordable Care Act reduced underinsurance by requiring plans to cover essential health benefits. And we'll talk about that a bit later. But that was the mechanism by which we're going to improve the quality of care and ensure that if someone is buying a plan, they're getting some minimum standard of quality. Now, the individual mandate, which is discussed on page 203 to 206 in your text, requires that most people would be required as of 2014. Remember, the law was implemented in signed in March of 2010, and it gave up until 2014 that individuals would then have to buy health insurance or pay a fine. Now, there were exemptions for certain populations based on affordability as well, but essentially the fine or the penalty began at $95 and grew to $695 by 2016 or 17, or from 1% to up to 2.5% of your taxable income, whichever was greater. Now, it's clear in retrospect that this fine is far too low to be a disincentive for people to not have insurance or an incentive for people to buy insurance, because $695 may be 1 to 2 months premium, and a year of insurance plus deductible costs will be significantly greater. So that was a practical problem. In any case, this was repealed. The penalty for not having health insurance was repealed in the 2017 Tax Cut and Jobs Act passed by the Republican Congress. Now, this mandate has been one of the most controversial features. Even among individuals who already owned health insurance, when they were surveyed, they said they didn't like the government telling them to buy insurance. And so one of the arguments was that this represented too much government interference in private lives. And there were constitutional concerns about whether it was legal for the government to do this. This was decided in June 2012 by the Supreme Court, although there is another case now making its way forward. But with respect to the individual mandate, it was decided by the Supreme Court that the federal government did have the right to assess this as a tax on individuals, and it was really considered a tax. That's discussed in more detail in the book. There's a whole section on this. But bottom line is, this has been a very controversial issue. Now, I would pose to you to think about this in the context of other aspects in our society. Why, for example, is there no such controversy over the fact that the state of Oklahoma requires us to have insurance to drive our car? Why should this be such a controversy when it's talking about health insurance? It's an interesting discordance that maybe you can think about, and we might discuss in more detail at a future open discussion session. The employer mandate said that employers with 50 or more employees must provide affordable health insurance or pay a penalty. There was a definition of what defines insurance as affordable. It has what's called an actuarial value. You can read about that in a bit of detail, but it should not be more than 9.5% of an individual's income. With regard to smaller businesses, its penalty is per employee after the first 30 employees, for all businesses, and this ranges from $2,000 to $3,000 per employee. For small business, for those less than 25 employees, there was tax credit provided to incentivize these businesses to offer health insurance to their employees. There were many changes to the private insurance market with respect to the Affordable Care Act. These are detailed on page 214 to 15 and listed in this slide. We've talked about some of these already. A very important one is the provision of preventive services. Again, President Obama's guiding principles wanted to increase the investment in disease prevention, which ultimately will help decrease the cost of health care in our country by making our population more healthy. And the Affordable Care Act insisted that private insurance must offer preventive services without cost sharing on behalf of the beneficiary. And the asterisk here says that any services that were rated an A or a B by the U.S. Preventive Services Task Force, that's the independent committee made mostly up of academics and healthcare individuals, not government people, who come together to review all of the evidence for different healthcare interventions, that if the intervention or preventive service was given a grade A or B by this task force, it should be covered under a private plan. It also said that all immunizations recommended by CDC should be covered, and women's health activities outlined under the guidelines by the Health Resources and Services Administration should also be fully covered without cost sharing. So there was an emphasis here on prevention as a way of improving our population health and ultimately of reducing burden and utilization of healthcare in the future, and hopefully to save costs. The other changes were to remove any prohibition by insurance companies on lifetime limits or annual coverage limits. Previously, many policies said you could not bill to them more than a certain amount per year or a total amount over a lifetime for a particular service. That was removed. It prohibited these insurance companies from canceling or rescission of a policy for any reason except fraud by the policyholder. It brought in an appeals process related to pricing and rate increases with respect to policies, and a process of rate reviews by these by an independent committee to look at the increases in premiums on an annual basis being charged as to whether this is appropriate and fair to consumers. And this was not a very well-received measure by, for example, the insurance companies or some others. And again, the medical loss ratios were defined for large group plans, for example, like Oklahoma, University of Oklahoma. It had to be 85% or greater, because once you get to a certain scale, it's easier to administer a large group. Small group plans, a little more costly, or individual plans, so the medical loss ratio was 80%. But importantly, the vast majority of what a person is paying in their premium should go to benefit their health through services that they receive. Some other changes to the private market: guaranteed issue, that means you can't be denied based on pre-existing conditions; guaranteed renewability; no medical underwriting of the individual. There is a variation in premiums across the country for different health insurance plans, and they put limits on these. And the only valid reasons would be age, geography, family situation. So are you covering 2, 3, or 4 dependents? And are you a tobacco user? These were the variables that were allowed to vary within pricing of the premium. The essential health benefits were defined that every policy must provide, and we'll talk about that further. And employers were incentivized to offer employees incentives to reduce the cost of their health insurance coverage. For example, a rebate on the premium for achieving certain health goals set by your physician, for example, keeping your cholesterol in range, losing a certain amount of weight, keeping your blood sugar in a certain range, and so on. And many companies then would issue rebates to the premium the employee was paying for their plan. However, some plans were grandfathered and were not subject to all of these changes. Now, this defines the essential health benefits under the Affordable Care Act, and this is listed in box 10.5 in your book. But here you see it's quite comprehensive. And importantly here, mental health and substance abuse coverage is clearly covered. That was highly variable prior to the Affordable Care Act. Rehab services, prevention and wellness, and pediatric service always included also vision and dental. Chronic disease management is also an important component here, where case managers are following up with individuals. Remember, we talked about enrollees in Medicare having 3 or more chronic conditions, some people having 5 or more, and having an individual a case manager who follows up with the patient, make sure that they're understanding and adhering to their prescription medications, that they're doing various activities that they're supposed to do with respect to their health, helping them with their appointments and various other things. These were added in as an important value to patients and would be paid for under private insurance. Now, the health insurance exchanges, or also called the marketplaces, were set up. The state health exchanges, there was an exchange called the American Health Benefit Exchange. This was for individuals. Now, it was estimated that this would cover about 8 million people by 2028, but that's quite a bit less than what this Congressional Budget Office, CBO, actually estimated would be covered under this program at the start of the Affordable Care Act. But as the Affordable Care Act was being implemented and the controversies persisted, fewer people dropped their employer-based insurance. So people came back and said, you know, I got good insurance through my employer. I'm going to stay there. I'm going to stay with that. This has historically been a challenge in our country. Many people have been afraid to change jobs for fear of losing or having reduced insurance. And with the repeal of the individual mandate in 2017, it's not likely that a large number, more than estimated, of individuals on these exchanges will be achieved. There was a small business health option program was in place. That was ended in 2018. Most of the exchanges offer the essential health benefits. Their exception is variance by different states according to the rules on abortion. The plans are required to have one of 4 levels in which this refers to the share of the benefits that are paid for by the insurer. In other words, the people providing the plan. How much do they pay versus how much does the beneficiary pay? And the share that the plan or the insurer pays is called the actuarial value. Now, there are a host of executive orders that President Trump initiated since his election, which have targeted these state health exchanges and their policies. Those are listed in box 10-2. They're quite extensive and listed there. Now, there were cost-sharing subsidies for low-income people in the Affordable Care Act, and particularly from the outset, since insurance was going to be mandated through the individual mandate, it was also important then to, at the same time, have some type of assistance for low-income individuals. And so premium tax credits were available for individuals who purchased insurance and had incomes between 133% and 400% of the federal poverty level. Cost-sharing subsidies were available for individuals who had incomes of up to 250%. So premium tax credits, that's where on your tax return you get a amount of money refunded back based on your premiums and your incomes. Cost sharing are where the government or the federal government will provide some funds to help pay for the part of health benefits that the insurance, that the plan does not cover. And to qualify these individuals needed to be a U.S. citizen or legal resident and not have access to employer-sponsored insurance. The next couple tables, 10-1 in your book, shows how premium tax credits are geared to income. So if you make 100 to 133% of the federal poverty level, then you get back a credit on your taxes at the end of 2% of your income. And you see how this is a progressive program where the premium as a percentage of the income rises. I'm sorry, I maybe didn't make that clear. The premium is lower for people with lower incomes based on federal poverty, and it rises progressively as income rises. This shows the premium as a percentage of the income. Cost sharing schedule, similarly, the more you make, the less the government contributes to that, and the more you have to share the cost. And out-of-pocket expenses, again, also had a schedule. So these schedules are provided as these tables in your book. Now, there were some financing changes brought in by the Affordable Care Act. There were changes in provider reimbursement. There were reduced payments for preventable hospital readmissions or admissions with the goal of getting people to be incentivized to avoid those admissions if they're preventable. And there were reduced payments to hospitals that had high rates of hospital-acquired infection. Again, an incentive to give a better quality of care and keep the patient well. There were changes to the Medicare Advantage reimbursement. Remember, this is the managed care plan for Medicare. There was a tax for high-income individuals for their Part A of Medicare. There were reduced subsidies on the prescription drug plan Part D for individuals with higher income. It eliminated the tax deduction for the employers who received subsidies to help their employees support their Part D plan or Part D prescription drug plan. The term DSH, or disproportionate share hospital, is on the next slide, and this refers to a hospital that does a disproportionate share of care to underserved and uninsured individuals. And since the Affordable Care Act was expanding Medicaid, in the future these individuals should have insurance to pay for their services. They should not be uninsured anymore. The logic went that therefore this extra payment should be reduced or eliminated. There was an increase in the amount of rebate that manufacturers of prescription drugs were required to give to Medicaid. There were some income tax code changes. There were some health industry fees, for example, a tax on tanning bed services. Why this was singled out? Well, tanning beds are a high risk for developing skin cancer or melanoma, but really because they didn't develop a tax for every risk area. Colleagues that I know who were lobbyists or other things in Washington said that this was put in as a way of poking fun at a particular congressman or two who used to obviously be visibly looking like that they were regularly using tanning bed services. And then there was a tax on high-cost employer health insurance plans. Those are the plans that are very, very generous. They were called Cadillac plans, and where the employer is paying quite a lot for those and the employee. Now, regarding uninsured and underinsured, before the passage of the Affordable Care Act, 15% of Americans were uninsured. Another 7.5% were at risk of bankruptcy due to healthcare costs because their insurance was not sufficient to cover all of their costs. And at that time, medical expenses were the most common cause of bankruptcy in the United States. With the passage of the Affordable Care Act, the proportion of the uninsured, proportion of our population who were uninsured dropped below 10%, down to around, as you know, about 9% or 8.9%. The major driver of this was Medicaid expansion, and therefore it's variable by state because not all states expanded Medicaid. Here we see the uninsured rate by state as of 2018, and you see again, based on the different colors, you see that the states with the darker green are those that have an uninsured rate of 12% or more, and Oklahoma and Texas and some of the other southern states are in that category. And you see that some states have achieved less than 5% uninsured, and others are working at 5 to 6.9 or 7 to 8.9. So there has been a major movement on the uninsured rate, but it remains high among select states shown here, as indicated in the slide. And for Oklahoma, it remains significantly high. And of course, we have not expanded Medicaid. Here is the uninsured rate in 2017 for working age adults, 18 to 64, working age adults who live below or at 138% of the federal poverty level. Remember, the federal poverty level is about $12,500, not quite, for an individual, and a family of four. It gets up. Family of 4 to 8, it's up near $40,000. It's not very much. so it's very challenged. But you see here that there are variance across the country with respect to the percentage of uninsured by county, and you can see which states have the highest uninsured rates for some counties. And you see here that some areas have uninsured rates of 40% or higher, and this is really profound, or 30% or higher. And if you look at all of Oklahoma, the people who are at this low income, less than 130%, 38% of poverty, have very high uninsured rates, 30 or 40%. And that is the rationale behind Medicaid expansion. It's very challenging for these people to be able to afford private insurance, and indeed for any companies to be able to offer private insurance at a rate that is affordable for these individuals and not lose money. And they're not in the business of losing money. Now, this was a previous article that I had included in the introductory course, and I just wanted to highlight again. This shows the percentage of adults 18 to 63 years of age, so not eligible for Medicare, right? But 18 to 63 who have family incomes above 138%, but below 400% of the federal poverty level. So the family income could be about $48,000 in general, although it varies by state and geographic area, and who had non-group private coverage. Okay, so it shows what happened to non-group private coverage among these low-income individuals after the full implementation of the Affordable Care Act. Well, you see that the insurance rate, here is the impact of the marketplace or the exchanges, and you see that didn't do much here. And then when the rules became enforced in 2014, and the benefits became provided, the subsidies, everything else, we saw a marked tick up in the proportion of people who have a non-group private coverage. So not an employer-based large coverage like the University of Oklahoma, but a private policy on the exchange. And you see that went right up to about 9%, from down at almost lower than 2 down to almost 1% here. And you see that these marketplace efforts, the exchanges implemented at the states under the Affordable Care Act, had a big impact at helping to reduce the uninsured. There was increased non-employer private insurance. There was increased outpatient utilization because people had a way to pay for it now rather than going to the emergency department. Increased inpatient care, additional use of prescription drugs that are appropriate, and increased diagnosis of high blood pressure, which is a major risk factor for cardiovascular disease and cardiovascular death. Finally, this slide shows the uninsured adults in the states that did not expand Medicaid, and there's about 14 of them here, but who would be eligible for Medicaid if their states expanded by current eligibility defined under the Affordable Care Act. And this is an analysis done by the Kaiser Family Foundation out of Washington. And here's what you see. For all the states that did not expand Medicaid, there's 4.8 million people, of whom 409,000 are currently eligible for Medicaid, and they may be eligible for the exchange here, marketplace coverage, eligible for Medicaid, marketplace coverage, and this is the, almost 5 million, 4.8 uninsured in all the non-expansion states. 409 would make it for Medicaid. Another 2.4 million have incomes less than 100% of federal poverty, and another 1.9 million could be eligible for the exchange coverage. Now let's look at Oklahoma. And we have here, based on this, 216,000 individuals uninsured individuals who would be eligible for Medicaid, and there's 19 currently eligible, 19,111 have incomes less than 100%, and then another 85 are potentially eligible for the marketplace coverage. So expansion of Medicaid in Oklahoma could add 216,000 people to the insured side of the ledger. Note that Texas is profound in almost 1.5 million individuals, uninsured individuals who would be eligible for Medicaid in some way or marketplace coverage. Finally, the final couple of slides showed a comparison of US House and Senate bills brought in immediately after the change of administration. The Trump administration was elected. There were two main plans, a House and Senate plan, the American Health Care Act and the Better Care Reconciliation Act. And what you see here is they're fairly similar with respect to things, but the general theme is that they remove taxes, they eliminate penalties, they eliminate the individual mandate, they allow states to define their own health benefits so they don't ensure a minimum standard for all health plans, and you can go on and see additional issues. This plan, both plans were trying to change the Medicaid program to a block grant as a way of capping spending, changing it from an entitlement program to a block grant. That's a very serious and significant change. And there were profound effects on women's health services. Both kept a dependent coverage until 26 because it was politically completely unpopular to remove that. And the pre-existing condition protections. So already you can see that no matter what happens with the political turmoil and the haggling back and forth that's going to go on, it's clear that the removal of pre-existing conditions and keeping young people on their parents' plan up to age 26 will survive. It's just untenable now politically to remove them. And there's a few more details here in these other, this last slide with respect to cost and what the impact of these plans would be on the uninsured rates. And this is made by the Congressional Budget Office, which is supposed to be a nonpartisan group that does analysis of policy for the use by Congress. And you can see that both of these plans would result in significantly more people being uninsured. These plans did not pass. So they are history now, they did not pass, but you can see where one side, really, this time the individuals in power being the Republicans having both House and Senate, and what they were trying to do with respect, which was really taking back many of the things that the Affordable Care Act advanced forward. So with that, we have concluded our discussions, and look forward to having the chance to talk with you further about health reform in the United States.